This is a surprise for me because I didn't know I was chairing this session. So I'm going to just put diabetes to one side and become a cancer expert straight away. No problem, no problem. So let's make Zsofia. Hello.
Hello.
I'm chair, so I get to ask some questions, which is good. A few things. You mentioned food additives. That really interested me, and I wondered if you could tell us, were there any food additives that you are most suspicious of?
I can very easily answer the question because it can be potentially anything.
Right.
And
Okay.
I can be more specific.
Well, I was wondering about emulsifiers because I know at Liverpool University are looking at emulsifiers because of their effect on the gut barrier. So I wonder about, have you heard anything about emulsifiers, particularly in terms of them breaking down? Because, of course, they're sort of fat-soluble, aren't they? So I just wondered if
I cannot answer this specific question because I do not know the background, but I can tell you that there are many individuals' sensitivities. So, for example, something just because it has been derived in a natural way from a natural compound, like anything that you can find in a toothpaste or beauty products, actually anything maybe containing something that is triggering of your symptoms. And if you had a very high intestinal permeability at any point earlier in your life, you may remain sensitive your entire life. So it is not that important whether it is something we know or has a name, or something it is as general as a milk residual, for example.
You mentioned then the permeability. I've heard you speak before, and there was a way that you could measure intestinal permeability. Could you tell us a little about that? Because I think actually, if you can measure something,
yes,
then people are more impressed.
Yes.
So I know you can do this, so please tell us.
They are absolutely right. And I wanted, but I didn't have the time to cover this. But this is indeed very important because there are, so to say, a few measurements to measure the intestinal permeability, but not all measurements are specific and sensitive enough. So there are at least 4 or 5, 6 measurements. There is also the measurement of the zonulin, for example, that is most well known in this topic, which is actually not a measurement, it is a marker that we can use to infer information. But so this is also something, but it is not a measurement, it is just a marker. The PEG 400 test, the so-called PEG 400, is indeed a measurement. That actually how permeable your gut is. You are, should I go on or that's enough?
That's probably it.
Okay.
I'm looking at Ben thinking we haven't heard a single word from him. And so let's pass on to Ben. Ben?
Yeah.
Cancer. What have you got to say?
Right. Well,
but not too long. But
the
not
nice
too long.
David, the blessing for David is when you're talking to an old, fully tenured professor, I got a lot to say about all kinds of things. So I will keep it brief. Where what would a metabolic scientist have to say about cancer? More than you'd think. Not to you guys, it's not a surprise. Although I approach this subject with enormous humility because cancer is a disease of change. It is unlike diabetes, which has such clear targets. This is you trying to hit the target as it's galloping away from you and moving all over. And I'm mindful of it because of my own family history. I was just speaking in the hallway. We were joking about me being number 9 of 13. And Jonathan and I were at lunch together, my older brother, and we cheated to get to that 13 kids. My dear mother, who had 9 freckled-faced, reddish-haired, blue-eyed kids, died of cancer when we were all quite young. And so it's something that we all think about quite often, even when we aren't trying to. So back to the matter at hand and metabolism in cancer, there's so much I could say about it, but I want to crystallize it to maybe the most compelling points, which is me invoking the work of Dr. Thomas Seyfried at Boston. Yeah, good. Where, let me just elaborate with you how elegant some of his studies are to point the finger at the mitochondria. The classic view of cancer is that it is a genetic defect coming from the nucleus. After all, the nucleus is primarily what's housing all of our genetic information. And what he did was take two cell lines. One was a line of healthy cells that were not cancerous. One was a tumor line or a cancer cell line. And then he created what he called hybrids, which is this clever way of saying it's a hybrid. And in one cell, he would take, so imagine we have a healthy non-cancer cell, and we take the nucleus from the cancer cell and put it into the healthy cell. Well, if cancer is a nuclear gene problem, what should happen to that healthy cell? It should become a cancer cell, and it didn't. When he would take the mitochondria from the cancer cell and put it into a healthy cell, now we were cooking with gas. That became a tumor cell, and it began to grow uncontrollably. So Thomas Seyfried's paradigm, which I'm just copying and telling you, this is not my work, it was that the cancer starts in the mitochondria, and that contributes to mutations that can perhaps affect the nucleus and the genes there and their variant expression. But independent, so his work really points the finger at the mitochondria. As a point of interest, Andrew had talked about the contrast, the dyes. Sometimes these dyes, the dyes that are sometimes used in cancer diagnoses are glucose. It's a radio-labeled glucose molecule that when you do an X-ray, it'll be really hot, or it'll show the X-ray. We do this because cancer cells will take in glucose at 200 times the rate of a normal cell. It is so hungry for glucose and glutamine, but it eats so much glucose that we allow that. We can leverage that to find out where the tumor is. And so why feed it? Why feed the beast? So when it comes to insulin resistance, some tumors have been identified, like breast tumors and prostate tumors, where part of the mutation profile is that they will have 7 times more insulin receptors than a normal cell. Insulin tells a cell to grow. In this case, the cancer cell is theoretically 7 times more responsive to that growth signal. But growth means nothing if there isn't fuel. And to make matters worse, we're not only spiking our insulin, but we're also feeding the tumor. We're fueling that growth by giving it all the glucose it could ever want. All right, that's enough for me.
Supplementary on that. So if what you say is true, where you're thinking it's not genetic but environmental.
Yeah, and I'm not implying that.
No, but just let me develop it. So I was just thinking, I have an idea that cancer is more common now than it was 50 years ago. Is that true?
Oh, yes.
And what do you think?
In fact, it's about to overtake heart disease as the leading cause of death.
And what do you think is the best evidence of that? Because if it's true, it's really worrying. And it's another one of the things we must wake up to and think about prevention.
Yeah.
Not waiting, and as you showed, Andrew, so well, the tragedy of just waiting and letting people get sick. Mm-hmm. It's too late. So what do you think is the best evidence?
Well, let me just, again, guys, wasn't Andrew's message just so heartfelt? I just really appreciated that message. I really did. Anytime you see a disease that is going like this, or anything in the human population that is going like this, you should immediately say that's not genetic. Because we're not mutating to become all cancerous. You know, men aren't evolving to have erectile dysfunction and low testosterone levels. That would be damaging to the species, right? So there's clearly something in the environment, and I truly, humbly have to say that's Zsofia's domain and the work she's doing in showing that if you change the environment, and Andrew's living proof, if you change the environment, clearly whatever genetic predisposition or genetic situation there may be, that cannot explain the trends that we've noticed. There must be something in the environment that is lighting it up.
Thank you. Thank you. Andrew, it must be you now, mustn't it? Hello, Andrew. Hello. I found your presentation so moving because I really felt I could inhabit, yes, sort of experience your world. And I wonder if going back, you've got a lot of clinicians here in the audience, and I have an idea that we may have something to learn from you. So if you could have your time again, how could some of those encounters be handled better? So what messages have you got for things that we could wake up and maybe do differently as clinicians dealing with people with cancer, which most of us do?
I think it's getting a bit better in terms of knowledge about the ketogenic diet and brain cancer in particular. It's still not great, but there's a bit more acceptance. But I find speaking to dietitians in the NHS that they're still not really trained in it. So when I initially had that conversation about saying, I'm going on this ketogenic diet, that conversation with my oncologist, it was just saying, well, we have some preclinical data about this, but it's not advisable and it's stressful, it's difficult. And so, yeah, I don't think that's changed much, but I'm hopeful that we can have better training there.
Andrew, what I was thinking about, I found it a bit heartbreaking that you rung up on a Friday as a really young person. You rung up and you're told, well, you're probably going to die, but we'll see you on Tuesday.
Yeah.
And I thought, so you're left alone, or nobody knows.
And I was asked, do you have any questions? And I was speechless. I couldn't.
Yeah. So that was one of the things that upset me most, was a young person left alone from Friday to Tuesday. And I wonder how would you have doctors or nurses, or how would you think that could be handled better?
Yeah, I think how patients are spoken to is, it's not just me who's mentioned this. I know other people who've had similar issues. That could be handled a lot better.
You see, so would it be better? I'm just thinking, how could that be better? So one of the thoughts I had, I think ringing people up, because they can't see your face over the phone. They can't see how devastated or who's in the room, so that they don't know when they ring you up your circumstances where you are. And I just wonder whether it might have been better to, say that Friday, it might have been better to see you, I think.
Also, I'd say don't speak to patients like they're idiots, meaning give them all the information. When I asked about the evidence supporting the standard of care for brain cancer, I'm being told it's palliative, and I was asking, well, what does that mean in terms of time? It's more like I was being seen as a nuisance, and I should just accept that I've been told it offers a significant benefit. Why are you going further into the details? And when I did eventually go even deeper into the detail, I found that it wasn't, on balance, beneficial for me and the genetic profile of my tumor. So then I was left with lots of emotions. I was quite angry for a while. And it was just not having all the full information, because the idea was, he won't understand this because he's not medical.
One of the issues for me, I think, is not to see patients as problems. I just get the feeling that you were thought of as a problem because you were asking a lot of questions, and so I think it's much better to be intrigued or interested and curious with what patients say and their experience. And then that changes. If patients shouldn't be problems, they should be an interesting puzzle. And then if you can do that with a patient, then you're working together, exploring this. And I wonder what you think of that as an idea, contrasted to your experience in the health service, which is...
Yeah, I'd say that was my initial experience, but after going to, there was a ketogenic diet conference that I went to in 2014. So I was initially at the Royal Marsden, and at the time they weren't very receptive to anything that I was saying about metabolic therapies. I then, after that conference, I learned about the work that Imperial was doing with studying ketogenic diets and brain tumours, and that Charing Cross Hospital was more receptive to this kind of idea, and I could discuss it with them. So after that conference, I moved to Charing Cross Hospital, and it became much better. And they were actually really interested in things I had to say. So that was a huge difference. I think sometimes it's different where you are. I had some time in Oxford at the John Radcliffe Hospital, and I spoke to the neurologists there about what alternatives I could consider away from anti-seizure drugs. And they were a lot more open to other centres where I was before, seeing other neurologists. So sometimes it's just about who you see, but in general, there is still that resistance to anything that's not the standard treatment.
I'm going to bring Zsofia back in a minute, but not only in a minute. Sorry. The next subject for me is compliance to do with diets, because that for me is the holy grail. Is we know things work, but they only work if you stay on the diet. And it's a big ask for people, isn't it? This slightly weird diet that you're on. So have you got any thoughts about what helps compliance? Now, one of the things that you said, which I thought Ben would like, you like alliteration, don't you, Ben? Yeah. So we've got Fitz as feedback. How about that? I thought you'd like that. Yeah. So, Andrew, in your experience, what do you think might help to do with compliance, where we're trying to motivate our patients to this big thing, these weird diets? Any advice on that or thoughts?
Well, the first thing that I came across when I was diagnosed, quite fortunately, was Tom Seyfried's book, Cancer as a Metabolic Disease. I think it came out in 2012, so I was in a good position, and I contacted him about the efficacy of this approach and how could I best apply it. And then not long after that, it hadn't been published yet, but he was telling me about the glucose ketone index, and I thought, okay, this is something I can measure. And it's nice to just to feel like you're taking control and to have those visible metrics that you can see, and then you can think, okay, I'm doing something that's helping me. Also, the kind of epilepsy that I had is just extremely sensitive, and so for me, it was very easy to stay motivated because I'd rather go on a strict diet than have seizures. I don't understand how. I know people who have a similar type of epilepsy who, for some strange reason, find it too stressful and find it less stressful having seizures. So that's a lot of people, and I don't. Yeah.
My wife is just, she's beginning to tremor over there. And Andrew, the reason is that I wonder, when you have intelligent people doing something that affects their health to do with diet, you have to just begin to wonder whether a form of food addiction could be taking place, because it's the same as people who smoke cigarettes. They don't think that's lengthening their life. And I think when we have real problems with compliance, for me, some of it has been food addiction, and they know that they're harming their health, but they can't help it. They really can't help it. I want to ask Zsofia, if I may now. So you must have learnt some stuff about compliance, because you've been doing this for years. Could you share with us, how do you keep the patients that ask you for help? What do you do about compliance? Because it is a problem for every clinician.
Yes. So there are many difficulties if a patient chooses this path. If you do not mind, I would like to go back to the clinical part. So we have mentioned what should
I was reading my notes. Sorry.
So we have mentioned the physicians themselves, how they relate themselves, and it would already be a big help to patients if oncologists at least do not oppose, and they should respect patient choices more than they are doing it now. Patients very often...
If I can just back you up, I agree. I think what we often forget is that, Andrew, you're an expert on yourself. So that you're not the passive recipients of my genius, just like a blank slate. That actually people they do know themselves, and they should at least be an equal partner in what happens to them and understand. And that actually, from a completely self-interested point of view as a doctor, if you do things with patients together, if it goes wrong, we take joint responsibility. Exactly. Because you and I discussed it and it's gone wrong, well, we went into this together. If, however, I tell you what to do and it goes wrong, you blame me.
Yes. And
then that's complaints and unhappiness. And so even as a self-interested doctor, there's a real benefit from asking the patient, so that relevant information, supplying relevant information, and then moving forward together, using your expertise in yourself. And that's what I'm fascinated by, is collaborative medicine. It's just more cheerful and interesting too, because people are so variable. And I've learned a lot from people.